Good afternoon, everyone. Welcome to the Rock Ethics Institute's Research Ethics Lecture Series. Before we begin, can I just remind you to switch off your cell phones? And there are sign-in sheets if you're doing this for SARI credit. My name is Jonathan Marks. I am the director of the bioethics program at Penn State. As many of you may know, we have an undergraduate minor in bioethics and medical humanities. And we also have a dual title degree program in bioethics for PhD students, where we're collaborating currently with the Departments of Anthropology, Communication Arts and Sciences, Biobehavioral Health, and now with the new College of Nursing. And we intend to add many more collaborating units to that PhD program in the months to come. I'm on sabbatical this year, but if you have questions, Aaron Height-Forsyth, who's over there is the interim director, should be happy to answer your questions, and I will be delighted to do so on my return. It's a pleasure to welcome you to the Rock Ethics Institute's Research Ethics Lecture Series, hosted by the Rock here at Penn State. I'd like to thank especially Jonathan Beaver, who is responsible for putting all of this together, and I'm going to give him the pleasure of introducing our speaker today. And I just want to add, it's a delight to have Art Caplan here. And I'm happy, while on sabbatical, to ride the wave that Jonathan has put in place. I'd also like to thank Nikolai Morar, who's also a postdoc like Jonathan here at the Rock Ethics Institute, and the staff, Rob Peeler, Deborah Triolonis, Carolyn Umbrecht, for their help in organizing this lecture series. Thanks, of course, also go to Doug and Julie Rock for ongoing support of work here at the Rock Ethics Institute. The talk today will last approximately 45 to 50 minutes, and there will be some time for questions at the end. So without further ado, please let me welcome Jonathan Beaver, a postdoc who put things together today, and it's our pleasure to have you introduce Art Caplan. Thank you.
Thank you, everybody, for being here on a lunchtime talk. We're really excited to have Dr. Caplan join us here at Penn State. Nikolai and I were really excited when we were organizing the lecture series last year to make the invitation and to have it accepted. We've worked with Dr. Caplan before in previous events, and he's a fantastic speaker, so I think it'll be a great afternoon. It's my very great pleasure to welcome Dr. Caplan, the Drs. William F. and Virginia Connolly Mitty Professor and founding head of the Division of Bioethics at New York University Langone Medical Center in the city. Dr. Caplan was the Sidney D. Caplan Professor of Bioethics at the University of Pennsylvania Perelman School of Medicine in Philadelphia previously, where he created the Center for Bioethics there and the Department of Medical Ethics. Dr. Caplan has served on numerous, countless really, national and international committees, received countless awards and honors for his work, including making several lists of the most influential people in the popular presses, something that all philosophers should aspire to, I think. None of whom will succeed, I think, except for Dr. Caplan. He is currently the ethics advisor at the Department of Defense, Advanced Research Projects Agency on Synthetic Biology, and a member of the National Council on Youth Sports Safety, among many other things. Additionally, and importantly, I think, for our work in bioethics here and in research ethics, he writes a column on bioethics for NBC.com, so he's involved in the popular press, bringing bioethics to broader communities. And he's a commentator on bioethics and healthcare issues for WebMD and Medscape, and is a regular commentator on medicine and science in radio programs in the Boston area. He appears frequently as a guest and commentator on various national and international media outlets besides those. In fact, his work is so well known and widely regarded that CBS has committed to the development of a pilot episode of a show called Austin's Razor, a medical drama inspired by Dr. Caplan's career in bioethics. And we're really excited about that possibility too. It's our very great pleasure to welcome Dr. Caplan here at University Park as part of our ethics series. Please help me welcome Dr. Caplan.
Yeah, if you know your history of philosophy, it's never good to be on the prominent list because ultimately they kill you. That's Socrates. Never a good idea. But thank you for that nice introduction. It's great to be here at Penn State. I was very honored to get the opportunity to be in the lecture series. What I'm going to do today is talk about vaccine mandates. I almost threw the whole talk out the window and thought I would talk about Ebola because I'm also on the WHO Ebola committee, but this may stimulate some thoughts on your part about mandates for vaccines relative to diseases like Ebola as well, and it's fine to get into that in the question and answer. Vaccine mandates is something I've been very interested in, and what that title up there, or that slide up there says is, what's the obligation of healthcare workers to get flu shots? And that's the case study I'm going to use to discuss mandates for the most part, 90% of what I want to talk about today. And I'll give you in advance sort of where we're going to go here. Sometimes when you're doing bioethics, how many of you are studying bioethics here? Well, how many of you are willing to admit it publicly? There you go. And how many of you have an impossible time explaining to your parents or your siblings what you're studying? There you go. So it's a common phenomena. That TV show may solve that was discussed. But another way to try and explain it is to say, does bioethics or ethical thinking about a healthcare issue ever make a difference? Does it cash out, or is it just asking questions and sort of debating around the seminar room different topics? This is an area that I got involved in, and I will tell you we have changed policy solely due to ethical argument. Not the facts, not the science, not the medicine, but the ethics. And I picked this area in part to show you that adding the ethics into a problem can make a real difference. We can argue about whether it's a good difference, that's a separate problem, but it definitely changed policies, not that it's beyond debate, but it took ethics and ethics arguments to shift the policy. So this is a very practical demonstration of how bioethics has made a difference in the vaccine space, and that's what you're going to see. And I'll bolster that claim by saying facts are not enough in many debates about what ought to be done in medicine or healthcare or nursing or social work or sports medicine. You also need to have a moral point of view that says this is the right thing to do. The old philosopher's chestnut about this, going back to David Hume, is you don't get from an is to an ought. You can hear facts all day. It doesn't necessarily make you want to behave differently or do anything differently. You have to have a motivation, a moral reason, a self-interested reason, something that's going to give you a fiscal incentive, but you have to have something that drives behavior beyond information. So, in the vaccine space, facts are definitely not enough. Vaccine advocates like to say people who are hesitant to use vaccines, the problem with them is they don't know the facts. I'm not sure that's true. We have seen, and you'll see in this talk, that there has been a growing number of people who don't vaccinate themselves, who don't vaccinate their children, or who have not gotten vaccinated, in fact, even though they are doctors and nurses. So I don't buy the argument, and never have, that those who don't vaccinate don't know the facts. I think there are plenty of people out there who know lots of facts. There are also plenty of people out there who are aware of what experts say about the facts, but see things on the internet that make them think there are other facts. For example, that you can give your child autism if you vaccinate the child. Commonly up on the internet. In fact, if you can test me on this in this room or do it when you go home, but if you Google vaccines and children, you'll get to concerns about autism pretty quick. They'll pop up fast. So there may be other facts in addition to what the experts say. There may be other fears, there may be other worries, there may be other reasons that people know the facts, that vaccines are beneficial, but don't act on them. So repeating the facts again and again doesn't necessarily respond to the reasons people have or the moral positions they might have for not vaccinating their children. Or let me put this another way. I understand why some parents don't want to vaccinate their children, because if they're worried that the vaccine will hurt them, then morally they don't want to hurt their child. So that's not a bad ethical position. Don't cause harm to your child is a reasonable moral position to take. I happen to think it's the wrong combination of facts with that value, but I get the value. So there are some zealous nuts out there in the vaccine area, but a lot of people who hesitate about vaccination do so because they have a moral desire to benefit their child. They just think that vaccines are dangerous in a way that they're not, but at the same time, you're not necessarily going to persuade them just by unloading more facts on them unless you address the basis for their fears as well. This is measles back in various countries, and you'll see US and Canada, while not having measles at the level of the Russian Federation, or some of those the darkest colors are the biggest measles outbreaks, some places in Africa and in China, we've had a lot of measles come back in the US in recent years. And as I keep saying, facts are important. They're necessary in thinking about any issue in healthcare in terms of what's right and wrong to do, but they're not sufficient. This is Brazil. 81% of people in Brazil get all the recommended vaccines for their kids, but it's only 76% among the wealthiest, best educated people. So the people you'd think would know the facts actually do poorer on vaccination with kids. There's just a little bit of vaccine facts. All this is saying is we had diseases like measles, mumps eradicated in France, meaning there weren't any cases. Britain, and they've all got them back. They had 15,000 cases in France. They had more than 2,000 measles cases in 2012 in England. The rest of these are showing you deaths when you don't vaccinate. Vaccine facts are pretty clear without getting into it too much. Vaccines prevent a lot of death. They also prevent, by the way, a lot of disability, which doesn't get mentioned as much in these debates, and they prevent also a lot of feeling lousy and not going to work. So the burden of diseases that are vaccine preventable isn't just who lived and died, it's also how do you wind up deaf because of the mumps? Do you wind up staying out of work for a week and maybe causing disruption and harm to others because you couldn't be a fireman that week, or you couldn't respond as a policeman that week? There are lots of sequelae or things that fall out when somebody gets a disease that was vaccine preventable. So now I'm going to give it the facts, even though I keep saying they don't matter, but we should know them, because I don't mean to say they don't matter. What I mean to say is they're not sufficient to get behavior change. So here's some facts, and now I'm just focused in on the flu. We are now in flu season. I guess I should ask, how many of you have had your flu shot? So pretty good, not bad, that's a good turnout. Although you need about 90% or better of people in this room to get a flu shot to achieve what's called herd immunity. That is, to make it hard for the virus to jump from one person to the next person. If you get to 90%, you start to see, you interrupt the chain of infectivity. It's the same thing with Ebola. If you have somebody quarantined, you're interrupting the chain of infectivity. So we had a good show of hands, but it wasn't 90%. So we've got to do better if we're really going to get the benefits from the flu. So some people say if you get a flu shot, it isn't that effective. And as a matter of fact, that's what something called the Cochrane Collaborative and other people up there have argued, that flu shots just aren't that good. That might be a reason not to get them. But as I just started to explain, flu shots individually don't always work, and here's why. In any given year, the virus that's the flu mutates. And so you're never sure what's coming, so the people who make vaccines have to guess what to put in the vaccine, and sometimes they don't get it right. So some years the vaccine's really effective, some years not as much. Is there carryover if you had the flu shot in a previous year? Does it help? Yes. So part of it's a little bit of a gamble. And how many of you know how we make flu vaccines? So I'll explain this. Basically, you take some of the flu virus and you grow it on the outside of an egg, on the white part of the egg, the albumin. For some reason, viruses like that environment, and they grow there. And then you get enough of eggs that have viruses growing on them. You extract all that stuff, purify it, and then you come over to a big factory and you start making the extracted viruses into lots of stuff, combining it together, and you shoot in a few other items to make a vaccine, and then you have to prepackage it into that needle that we all love. So you're in a factory using as your raw material viruses grown on eggs. Some years, for some reason, the virus doesn't like the egg as much and it's slower to grow. That's sometimes why flu supplies are slower. They're not always available in September because you're waiting for the eggs to develop the virus. Sometimes it's hard to get a flu shot from your doctor because now where do you get a flu shot a lot of the time? CVS or Walmart. They're big buyers, they buy them first. They get the contract, and so the hospitals and the pediatricians may not get the vaccine first. It goes to Walmart, which is one of the ironies. That may not be the population you want to get first, and I'll explain why that is in a minute. But be that as it may, we have an effective vaccine. It is, and now I'm going to tell a dirty little factual truth, the older you are, the less effective the flu vaccine is. Even though we yell at older people to get the flu vaccine, they don't build as strong an immune response. Newborn babies can't build a response at all. They are really the most vulnerable, and sometimes people ask me, should I get vaccinated if I'm pregnant? Absolutely. A big killer of babies in utero is the flu. You don't have to worry about harming the baby from the vaccine. You want to worry that you get the flu and you make your own baby spontaneously abort. So there are about a couple hundred spontaneous abortions each year worldwide due to flu in pregnant women. But the pregnant mom builds up a good response and transmits it to the fetus, so that's a good situation. And guess who responds the best to the flu shot? People in this room, college-age people, sort of from 20 to maybe 60. That's your best flu response, immune systems really responding to the flu shot. Why is that a good thing for the elderly? Because then you don't infect them. So part of the story about flu vaccination isn't just, am I protected? It's if I get the flu and I infect somebody else, are they going to get sick, the newborn or your grandparents? Now, we do give the flu shot to the elderly. They make some response, and in all honesty, some people respond better than others. And for the flu, even if you still get it, it won't be as bad. So that's one good thing for an older person. If they do get the flu, they don't stay sick as long, they don't stay, if you will, as sick intently. So the symptoms aren't as bad. You still may get it. Some of you may say, anybody had this experience? I got the shot and then I got the flu. The flu in any given year is only about, on average, 80% effective. Remember, I told you had to guess the strains. So it is possible to get a flu shot and get the flu. It's also possible that if you're vaccinating 20 million people, somebody already had the flu when they got the flu shot. And we see that a lot. So there are a lot of folks who do get a flu shot and then say, that gave me the flu, which it won't. But they already had the flu, and then it just showed itself within the next few days, and they say, oh, it must have been the flu shot. So those are facts about effectiveness, and sort of in philosophy we call that post hoc propter hoc. You know, something follows something. You say, well, that was the cause, but it isn't. It's just a coincidence. You already were sick when you got your flu shot. You just didn't have symptoms. You can be asymptomatic for 48 hours and have the flu. So there is a period, and by the way, just like Ebola, we've all been watching people say you don't have symptoms. Doesn't mean they don't have any virus, but you need to get a high viral load, a lot of virus growing in you to show symptoms. The flu is exactly the same. You could be infected, but not have a big viral burden. You're not going to show any symptoms. So the same phenomena going on. And as I've mentioned a few times, whether it's effective or not isn't just whether you're dead or not, but it is symptom control and whether you're infective to others. To put it in ethics terms, most people get a flu shot to protect themselves, but I would argue it's equally important to get a flu shot to protect vulnerable people. In addition to newborns and the elderly, if you're immune suppressed, if you had a transplant, if you're on cancer therapy, if you're a person with an immune disorder, you can't benefit from a flu shot. Your only protection is to have somebody get vaccinated and not give it to you. So that's what I mean. It has benefits for others. There is a notion, and we're going to generate it pretty soon here, that there might even be a duty to get yourself vaccinated to prevent harming somebody else. That's the death rates, and the reason those numbers are so wide, 3,000 to 50,000, is it depends how nasty the strain of flu is, right? Is that right? No one wants to nod? Okay, I'll nod. Yeah, that's right. The flu in any given year can be mild. The flu in any given year can be nasty. And the nastiest recent flu we had was pandemic flu. Oh, we long for the days when we were all worried about pandemic flu and not Ebola. But pandemic flu was just a flu that was nasty strain. It's nothing magical. It was a virulent, easy to transmit version. In any given year, this strain can be nasty, but hard to transmit, or easy to transmit, but mild. And that's why the death rates go up and down. It always causes a lot of hospitalization. NYU and Bellevue, where I work, Bellevue's the place where the last Ebola guy is, by the way, and he's doing better. I think he's going to come out this week. We have a jammed emergency room. Every January, February, we're overrun with flu patients. Hershey would be 2 here, or south of us, the med school branch. You just get loaded with a lot of flu cases. So the best way, again, to prevent deaths and hospitalizations and disability is to get above that 90% flu shot measure. We did have deaths in 2013. Almost all the kids who died did not have a flu shot. So it will kill kids, and the kids there are mainly babies, newborns up to 6 months. How do we know that flu shots work? Well, we've done some studies, and we've done something very interesting in switching toward a particular subgroup here that I want to talk about, which is your doctor and your nurse. And I should add your dentist. For most people, the healthcare worker they see the most in any given year is their dentist, not necessarily a doctor or nurse. Doctors and nurses, well, let me skip this. I'll come back to this in a second. The bottom line is flu is deadly, especially among vulnerable populations, the newborns, immunosuppressed people, very old persons. It takes a big toll in terms of hospitalization and impact on the workforce. Vaccines are somewhat effective. They're not 100%, but they're pretty good, and they work better when everybody gets vaccinated. That's your key to best use of flu vaccine. And healthcare workers are the most likely people of all to be exposed to the flu because they come into the emergency room, and again, I hate to make this metaphor, but it's just like Ebola. You're not going to get Ebola. Doctors and nurses who treat patients with Ebola are at risk of Ebola. If you sit in the ER and treat people who are sick with flu, you get flu. I mean, you could try to mask and all that, but it's hard to be 100% effective, just like the 2 nurses in Dallas who got infected. A lot of transmission is taking place into healthcare workers. The CDC recommends that everybody get a flu shot who will respond to it. That's basically everybody over 6 months. And they still recommend the elderly do it for the reason I said. It makes the disease less nasty to experience, even if you still get it as a person, say, over 65. But the public doesn't do this. General population flu vaccine rates, even with Walmart and CVS in the game, still under 50%. Pregnant women, still under 50%. A lot of pregnant women are afraid to get shots. They're just worried that it'll harm the fetus, whereas, trust me on this, it's better, far, to get a shot. Get your shots when you're pregnant, even if you are pregnant, to benefit the fetus. There's a lot of pixie dust out there about flu. This is something you could buy. There are a lot of products like this. VaxiShield. I don't know what the hell is in VaxiShield, but whatever it is, it doesn't work, but you can buy it online. That's where I got this picture. I pulled it down. The Federal Trade Commission chases these guys, but it takes them years to catch up, so they sell a lot of stuff and then disappear. It's $30 a jar. Flu shot's about 10. That's true. The shot's no pain in the neck. I mean, the shot's no dream, but people do prefer sometimes to take stuff that's powdery in water. This is one of my favorite ones. This is, if you can see it, it's sideways, but that's vitamin water. And it says sideways, flu shots are so last year. That was on the ad for the stuff. Now, trust me, that doesn't do anything to protect you against the flu. In fact, all that does is give you diabetes because it's full of sugar. So despite these recommendations, people don't get vaccinated. But guess what? Your doctor, your nurse, and your dentist don't get vaccinated either. Their rates hover around 60%. Now, for those who don't know hospital life, any of you been hospital volunteers? So then I'll explain to you. What we do every year is we usually have a flu jamboree. And a cart appears with flu shots for doctors and nurses. And there are often free hot dogs. And if you're in a really fun place, there might be a clown. And everybody gets all excited and tries to get you voluntarily to get your flu shot. But still, the rates are poor. Here, they continually hover on average around 60%. There are plenty of places that get lower than that. What was the magic number that we want to get to in a community? 90, so they're not there. And it's not just us. I've checked. The flu rates in Britain are poor, in Italy are poor too. I had a chance to, at this WHO meeting on Ebola, I was just talking to their health commissioners, and they have challenges with their healthcare workers about getting them vaccinated too. This data is a little bit old, I think it's 2 years, but it is from hospitals between here and Philly, and you can see the rates that I got by doing a little samples in some of the smaller places outside the big city. Nobody's at herd immunity rates there. By the way, when we're talking about vaccines and healthcare workers, we're talking about nursing homes, dental office, home care, not just hospitals. So if someone's coming in and you have an immune disease and you're getting some home therapy, you would very much like to have your healthcare worker vaccinated. It doesn't have to be in a hospital setting, and it could be, and you can ask this now that I'm torturing you, if you go to student health, ask them if they got a vaccination. Just saying. So a lot of the healthcare workers, if you ask them, say, I know I should get a flu shot. In fact, a lot of people around me seem to be at risk of getting the flu. 70% say that. 60% say they're at risk of getting the flu, which is pretty funny. So they think you're more likely to get it than they're more likely to get it. That's a fact. And why do they have these crummy rates? Why don't healthcare workers who know facts, I mean, assumedly we've thrown facts like the facts I've thrown at you, they would know these facts. And still they don't vaccinate. They say, according to some studies that I've published with colleagues, bioethics can work very nicely with social scientists, and so we've done a lot of questionnaires and surveys here. I stay home when I'm sick. I don't have a lot of contact with patients. I don't get the flu. I can wear a mask, and the shots don't work. So those are the 5 most common reasons. There is a 6th, but it didn't make this list, and that's fear of autism. It's still out there even among healthcare workers. Well, remember what I told you about reason number 1 here, I stay home when I'm sick. That's nice, except it's contagious highly for 24 hours before symptoms, and you're actually infected 48 hours. So you can be a carrier and not feel sick, so staying home isn't a good strategy. By the way, healthcare workers never stay home. If any of you are any doctors in here? So if you were going to medical school, you know, you go to medical school and then you become a resident. And if I, as a resident, had said, I don't think I'll come in today because I'm not feeling so well, I would be scrubbing bedpans for the next year. Nobody stays out. Nobody. It's an ethic of go to work, sacrifice, drag your butt in there, don't leave a shift short, don't leave somebody double shifting, you don't stay home. Healthcare workers don't stay home, by the way, too, because they don't get a lot of sick days to stay home. So nurses probably only get 4 or 5 sick days a year in most employment settings, and they're not going to take them for sick days. So the notion that you stay home, A, is stupid, and B, doesn't happen, just as a fact. So all of those reasons, and I may give you a few more if you want, but I think they're pretty self-evident. People who don't have patient contact, if they have some, that's trouble, because you can give it to other people when you have it. I never get the flu. You may not be a person who's relatively young and healthy who has severe symptoms, but you can definitely be a carrier and give it to your patients. And who's in the vulnerable group? Patients, immunosuppressed, old, babies. I can wear a mask. You could, but you have to wear it properly. And we'll come back to that, but I'll describe it to you this way. It's a huge pain in the ass. to wear a mask. Just hard to do it properly and not let the virus get through the mask. And the shots don't work, I already explained. They work better when everybody gets them. They're not individually as good, but together they work best. That's the herd immunity idea. So we have a bunch of facts. Flu is killing people. We got this vaccine. It's pretty good. It's not great, but it works pretty well. It works better when everybody gets it. We've got a lot of people out in the world who don't get it, who should. But we've got a lot of healthcare workers not getting it, who should. I can't give you the rate on dentists because we don't have that questionnaire back, but I'll phone it in to Jonathan and he'll report it to you. We're doing a survey. We got the list for all New York State dentists, so we're going to ask him how many got a flu shot. But your dentist, remember, wears a mask, and then he takes it off and he tells you his political views, and you sit there and suffer, and he breathes on you. So this is a high contagion environment. So there's a danger out there of flu. There's a need. We have something that could help a lot. I haven't said it yet, but the evidence for autism to the flu vaccine is nothing. There isn't any link between the two. There was a study years ago that tried to make a link between the measles, mumps, rubella vaccine and autism. I don't think that works either, but it has nothing to do with the flu. It just spread over to vaccines. So the original paper, which got retracted and then the guy lost his medical license, was linked up to the measles, mumps, rubella vaccine, MMR as it's sometimes called. It has nothing to do with flu. But the fear spread out that somehow flu was tied up to autism. One other reason I know that the flu vaccine isn't bad, for most of us sitting in this room, we can get a flu shot because if we're not autistic by now, we're never going to be autistic since you're 20 or 15. I mean, this isn't a vaccine, you know, we're not going to turn you into some kind of autistic person because you're too old. You'd be autistic already. No one gets late onset autism from a flu shot. And in addition to their being safe, the side effects of flu shots are trivial. There's pain, occasionally you get a little bit of symptoms, but there's no reported deaths from flu shots. I mean, they don't do anything that way. So, how are we going to get the healthcare workers to get their shots? Why is that important? Because they are big agents to infect us if we go to the hospitals, and they're infecting a very vulnerable group. And it might be important for them to do it if we're going to get you to do it. But the facts aren't making them do it. We had the jamboree, the clown came, we gave out the hot dogs, 60% or worse in a lot of places. Volunteerism not working. So what about a duty to get your shot? So this is bioethics in action. How might you generate a duty that would require someone to get a flu shot who's a healthcare worker? So I have put up 4 principles. Pretty simple. Didn't have to look them up in Kant to discover them. They're just simple principles. One principle is protect the vulnerable, weak, and defenseless. That is a duty of a healthcare worker. 2, patient interest first. That is your interest over what, if you're afraid of shots or you don't feel like it, it doesn't matter. You have to protect your patient because you put your patient's interest first. Do no harm is our old favorite principle that is rattling around in medical ethics all the time. Don't make people sick is a version of do no harm that you don't want to do. And then be a good role model. If you get a shot and you wear a badge saying, I got my flu shot, then maybe your patients will get a flu shot. It looks a little hypocritical to say to people, go out and get your shots, including your flu shot, if you haven't gotten them. So these are principles I think I will defend if we want to discuss them, but there's another amusing aspect about them. They don't permit exemptions. They don't say, do no harm unless you have a philosophical worry about flu shots. They don't say, do protect the vulnerable and weak unless you have some sort of religious belief that says it's okay to harm the vulnerable and the weak. Some people will sometimes invoke as a reason not to get shots religious objections. You may have heard that. So how many organized religions oppose vaccination? Actually, Christian Science and 1 or 2 small evangelical Protestant groups. There's no other religion that opposes vaccination because actually in the great books of all religions, Hindu, Muslim, Catholic, Jewish, Vaccination didn't occur to the 20th century. They had nothing to say about it. There's no comment on it. And most religious leaders are fine with it. They'll tell you to get a flu shot or whatever shot. There's no religious, unless you're going to say, I can't take medical care because I have to rely solely on God to heal me, which a few small religious groups do, like Christian Science. Nobody else cares. And trust me, there is nothing in the Quran on flu shots. No Buddhist has ever commented on flu shots. They didn't exist. So the religious objection is basically a philosophical objection. I don't want to do it. It's just gussied up in a religious language. But I don't want to do it doesn't stack up relative to these principles. Only healthcare grounds would be allowed, and there is a healthcare reason. Some people are egg allergic, and flu shots, I told you, are made on eggs, and so that probably is a problem. That might be a reason not to get a flu shot. Outside of that, not many other health reasons not to get one. You might say I have a history of respiratory diseases, or I myself have an immune disease, and so then you wouldn't benefit from the flu shot. It's not going to make you sick, but it wouldn't do much, so that might be an opt-out. Everything else, I don't think the principles are going to give you any exceptions. We already went through this, but I'm going to do it again. The flu preys on vulnerable people, babies, children, the pregnant, the elderly, immune compromised. They require protection. You are a risk to them. The best protection is herd immunity. Follow those principles. You ought to be getting a flu shot. And guess what? Just for my own amusement, not only did I decide to concoct these principles, I went to see if they were in the code of ethics of all the healthcare professionals, and lo and behold, they're there. And I didn't even put them in there. They made them up on their own. All the codes of ethics say, put patient interests ahead of your own, turns out. There's an example from the World Medical Association Code of Ethics. Act with the safety of patients as its foremost interest. Sounds good, very moving. To do it, you'd have to get a flu shot. Physician must recognize responsibility to patients first and foremost. I'm with you. Got to get a flu shot. Nurses, primary commitment to the patient. I mean, professions love to talk about how they love patients. By the way, so do pharmaceutical companies. It's in all their self-imposed codes of ethics. Nurse promotes, advocates, and strives to protect the health, safety, and rights of the patient. I'm for that. So how would you justify not having a flu shot? That's the same principles that I'm showing you about do no harm and protect the vulnerable and put patients first. Without beating this totally into the ground, if you don't get your flu shot, not only are you infecting the weak and the vulnerable, but you're not available to work when flu season's around, which is a big headache. You feed vaccine fears and anti-vaccine sentiments. People wind up using that pixie dust stuff I showed you. So you're a crummy role model. And they're a key weapon in protecting patients in nursing homes and hospitals, because in those settings, infectivity is high because you're going to be spreading it around within the institution. There aren't many studies of nursing homes and hospitals on increasing the flu vaccine rate and decreasing the flu, but the few we've got, the more you get the staff vaccinated, the lower the flu rate. It's not huge evidence, but it's what we've got definitely shows the relationship. The problem is the hospital isn't a completely self-contained environment. TV people, florists, your relatives, other people coming and going, so you don't have a pure case to really study. But to the extent nursing homes sadly get fewer visitors, they show the correlation stronger between getting the staff vaccinated and lower flu rates. Hospitals are a little tougher because it's such an open sieve in terms of who's in and out. There is evidence that if you get a flu shot, all that says, I won't make you read it, is that when nurses did it and let their patients know they did it, more of their patients got the flu shot. So there's a study, at least one, that does show that role modeling really does help. And by the way, for wimps and weenies who don't like shots, there's other people who have to get mandated flu shots. In the military, informed consent to shots consists of which arm? There's no exemptions. You want to work on the oil derricks out in the Gulf, you have to get a flu shot. Astronaut candidates all have to get all shots, including flu. As you know, school children have to get shots, although the exemptions are big if you don't want to do it. But there is a mandate in that sense, or a presumption that you will get a shot. Immigrants, interestingly enough, have to get flu shots. They don't have any right, legal ones, to refuse either. So, I think you can generate from the four principles a duty, an obligation, one that you could only get out of by a health reason for doctors, dentists, nurses, anybody with patient contact, social workers, respiratory therapists. I think you could say, if you want to work here, you get a flu shot or you get fired. That's what I mean by a mandate, strong mandate. That argument I just made has led to this, which is there are now 400 health systems with mandates for flu shots around the US. And this year, for the first time, New York State, I work with the health commissioner, has a vaccinate or mask policy for all healthcare workers. Starting right now, flu season began. So does LA County. And the Defense Department put it in for all Defense Department healthcare facilities. That would be like Walter Reed, not the VA, but the military hospitals. We're working on the VA. So here, just to recap, facts did not move behavior, even for a well-educated group like healthcare workers. When you made the moral argument that they ought to do it because they should put patients first, be good role models, do no harm, and protect the weak and the vulnerable, some of the hospital systems were now up to about, I think, probably 15% of our hospitals at this point, I think it is. Put the two together, the moral argument and the factual argument, and we move to healthcare worker mandates. That's what's emerging right now. So if you want to go home and say, I went to a bioethics talk and who cares, or I'm studying this and what difference does it make, that's your difference. We have a move toward mandates. Would it happen without the ethical arguments? No, it did not. It hadn't moved in, I don't know, flu shots have been around for about 40 years. No mandates. You put the duty to do it on the healthcare worker by motivating the argument, and we now are seeing a shift in policy and behavior. And indeed, it's a policy shift that's been endorsed by all of those groups on the bottom of the slide. They want mandates in every hospital, nursing home, and home care program, or state mandates. Pennsylvania may do it. We're talking to them through the health department. So we have a lot of backing from key professional groups to do the mandate. Well, there's the number. 13% now work at institutions that mandate, and at the ones that have the mandate, the rate is 98%. Now that's herd immunity. That's good. Children's Hospital of Pennsylvania went to a mandate after voluntary efforts failed, and we had some babies die. This is when I was working back at Penn. CHOP is our pediatric counterpart, and we put in a policy that basically said, if you don't get a flu shot, as is your duty as a healthcare worker, then you will be fired. And 7 nurses declined to get their vaccination, and they got fired. The rate now, last year, was 99.3%. It's really important to get vaccinated at a kids' hospital, a lot of newborns, pregnant people. It's a high, high-risk vulnerability place. And you can't get hired there, in addition, now unless you get your shot. So that is that's about as strong a mandate as you're going to see anywhere. We didn't, however, just wake up one morning and say we're going to impose this. We did go around, and I gave a lot of speeches with my bright idea about mandates to each department and tried to persuade them, just as I've tried to present it to you, that there's a duty to do it. We didn't just announce one morning there's a mandate. We tried to soften up the audience by saying, here's why you ought to do it, and they were pretty good about it and came to understand it. And I'm going to tell you something else. The food handlers, the cops, security, and other allied healthcare workers said, we want to do it too, because if they're going to do it, we ought to do it, because aren't we around the kids? And so they came in voluntarily to the mandate. And that's role model behavior. The next step, so one of my friends said, you're just trying ultimately to make sure everybody has to get a flu shot by mandate. Yeah, that's true. But the next step would be you can't visit in the hospital unless you have a flu shot. And then another area where flu runs rampant is daycare. So we have 3, New York City, Rhode Island, and Connecticut, all put in last year flu mandates for kids to go to daycare, or you stay home when you're sick, which no parent wants, to be home with their kid, bad. And indeed, the daycare teachers said, we're with you. We didn't have to fight them. They said, we get sick all the time. Vaccinate the crimpy little buggers. There are other groups you could see up there that we might extend it to. New York City, Connecticut, Rhode Island have the daycare pre-K thing. I like that. We'll be able to study that and see if it does any good. You could certainly get other people who work into the hospitals, Comcast or somebody could agree never to send anybody who hasn't been vaccinated to put your cable on and that sort of thing. Teachers and airline personnel more generally, there's certainly high risk in terms of being in contained environments with a lot of people. Other nations, Canada and British Columbia has now picked up the idea of a mandate. It could go through. We'll see what other countries might do. I'm sure they're all watching what happens here. Do you want to mandate for other vaccines? You might. That healthcare worker argument would probably extend to pertussis or whooping cough for people who work in children's hospitals, so I can imagine pushing that one through. And the ultimate example, or the ultimate point is to drive it further and try to get the public to do more by being a good role model. So not only do I want the vaccine mandates to happen, I want big banners. I want everybody wearing a button say, I got vaccinated, or this is a vaccine, infectious disease-free zone or a flu-free zone because we got our vaccine. I want people to show it off, because that's the idea of trying to drive the thing out like a ripple effect into the general public. So, to wrap up or to come back, people say often, I don't think ethics makes a difference. I don't actually believe that. Throughout my career, I could tell you a lot of examples where an ethical argument made a huge difference. Some of them you know. Informed consent to research. We didn't have that when I started, and we do now. Some of them you know because you watch end-of-life care debates take place with people asserting their right to stop medical care, which didn't happen when I first got into this. This is a nice example at the public policy level of making a move. Everybody knows the facts. They know that the vaccines are pretty good. They know there's a need. They know that people are dying in tens of thousands. By the way, think about it. Ebola, flu. I mean, you really want to worry a lot more about flu. If you want to worry about something, worry about flu. If you want to worry about something, wonder about who you're sitting next to on a train or an airplane who might have the flu. Much more likely to get it than Ebola, which you have to kind of bleed onto somebody or have diarrhea onto somebody to get. Well, don't want you to go away without some disgust in this talk. So, but flu is much more nasty. And by the way, comes in from other countries because it always starts in the other hemisphere. The season there begins before we do. So it comes from Asia or Australia. So you could, if you were Governor Christie or Governor Cuomo, quarantine for flu. You'd get more impact than Ebola, as a matter of fact. Just saying. But aside from that tangent, we know the facts are there. You should get a flu shot to protect others as well as yourself. The more of us do it, the better it is for everybody. The highest risk spreaders are healthcare workers just because that's where the flu comes, that's where they get it, and they're working around vulnerable people, but nobody did anything about it until we generated, or I tried to generate, a moral case that said, given what you stand for, patients first, do no harm, protect the weak, be a good role model, I think you've got a four-legged stool that's going to give you a duty. And it's a strong duty, not one you could opt away from very easily unless your health was at risk. And believe it or not, it worked. People bought it, so now we have a lot of healthcare systems doing the mandates. We'll be able to study it. At Children's Hospital, where I was, we had good data going back 20 years on flu and flu deaths. So we'll know right away if there's going to be a correlation between 99% flu vaccine rates and deaths. We'll also have some labor numbers about who's at work in flu season. So we could even see if there is an impact. There's a little cheating that can go on here, though, I have to confess. Remember I told you each year the flu, some years it's virulent and nasty, and some years it's not so bad. Next year, it might not be so bad, and the flu rates will go down in terms of death and disability. Now, I could jump up and say, see, I told you, vaccinate everybody, it's going to be good. But the real truth is you probably have to watch that for a couple years and let different intensity of flu strains appear before you can make a claim. Although, check me on that, I may get on TV and still claim victory after 1 year. It depends on my mood. So there it is. It's all laid out there. You can see the moral argument, changing people's minds, getting support from administrators, but also from doctors and nurses. We're trying for dentists, trying for daycare. Is there a ripple effect intended? Yes. But I think you can make a difference with the right ethical position. It doesn't mean somebody couldn't critique my argument about the principles. We could debate them. I'm happy to debate them. It doesn't mean that every time somebody utters an ethics duty that people are going to do it. But in this case, appealing to healthcare workers who generally want to do the right thing, just like our friend, the nurse who came back with Ebola, I don't think she wanted to hurt us. She was just trying to say, I'm not infectious, I don't have the disease, you don't have to lock me up. Since she went and faced Ebola in Liberia, I suspect she's well-intended as a person. Most healthcare workers don't want to hurt babies. They don't want to kill immunosuppressed people. They're not that interested in murdering the elderly. So I think in general, you can move their behavior because they're starting from a place where they want to do the right thing. You just have to sort of position it so ethically it comes out in the right direction. So I'm going to stop there, and I'll go sit there if this comes out. Yep. And then happy to take any questions or comments that you might have. Thanks.
You mentioned that there were no reports of flu shot deaths, but in the last few years, the U.S. Department of Health and Human Services has conceded and compensated hundreds of cases of flu shot deaths, as well as neurological disorders, autoimmune disorders, seizure disorders. You didn't mention any of those, and I'm wondering how ethical is it for you to be arguing for a mandate of vaccination if you're leaving out those key facts?
So there have been compensation, and there's compensation for many more vaccine injuries too. We have a vaccine compensation fund, but the vaccine compensation fund doesn't make any concession about cause. What it says is, well, rarely, but I don't think, well, I'm going to tell you, not for flu, not for flu. Do you know any instance of flu? Well, I'll say none, and you can say one, but I'll argue for, I'll just say, I'm telling you, the link between compensation and cause is not there. It's meant to be generous. Anyone who claims an injury, if you will, for a child or whoever post a shot, they have a very good chance to get the compensation. And I don't oppose it. It's fine. It's fair enough to do that. But if we now go to the studies from the legitimate places, flu comes out very, very well. Or let's put it this way. We had at the Children's Hospital in the year before we did the mandate, 13 dead babies. I can think of one case that will argue it, but 13 in one institution for children, I'm taking the flu mandate. 2010.
From a different perspective, I'm an educator here at the university, and a lot of the folks in this room are students. So how rapid do you think, in the best case, it could be before we would start to have a conversation about whether or not university employees, with our high contact rates with students in the classroom, or students should think about something like the flu vaccine being mandated?
Tomorrow. I mean, we went to NYU Student Health and said, what are you doing? And how do you discuss this and present it and so on. Now, remember, there are mandates. Meningitis, for a lot of schools, is a mandated vaccine. Enforcement isn't strong, but the mandate is there. So for a lot of places, we've had meningitis outbreaks take place. We've had deaths. There was a new strain of meningitis vaccine B, meningitis B, that broke out. We just got an approval for that particular vaccine, which was only approved prior in Europe. I think HPV vaccine, flu vaccine, there's a lot of interesting questions about where is student health on those. Some of them are not as imminently important in any given time. Some last for a long time. Meningitis is a high transmission in the dorm kind of problem, so that becomes a special college issue. Flu has that too, although I would concede that few healthy 20-year-olds are going to die of the flu. That isn't, there you're probably still trying infectivity. I mean, more than preventing death. But I think it's a discussion to have. I absolutely do.
The case for flu sort of is, okay, maybe debatable, maybe not. But the vaccine is relatively safe. But some other vaccines are more dangerous. So for instance, when the smallpox vaccine was given out after 9/11, a lot of healthcare workers chose not to get it. And with the smallpox vaccine, there's a very small but legitimate chance they can kill you. So if we want
Certainly, the
generalize,
anthrax vaccine looks that way. I'll give you that one.
so if we want, what we really need to make a decision is some sort of number to sort of nail things down. At what level of risk does it become all right to start saying, well, this is a level of risk where we can start mandating something?
Yeah, that's a fair point. And for me, I think when you get strong studies for safety and you see deaths at the numbers like flu has, you're kind of over in the let's mandate. I think you've got anthrax is out there. I think the chance of getting anthrax is like the chance of getting Ebola. It's going to be hard to justify a mandate there. I think if you choose someday to get the, by the way, 7-shot anthrax series, I don't see anybody, on the other hand, declining rabies when they have it. I've never seen a vaccine refuser. And I suspect tomorrow, if we introduced an Ebola vaccine, people would be lined up from here to Mars to get it because they're scared out of their minds about a disease that I don't think they have any reason to be scared about. So some of it is fear. Some of it is, what's the chance that I'm going to get this? Flu, you have a pretty good chance. I would say anthrax, hopefully not, but it's not high up on my list. So I'm willing to take them case by case and arguing them out, sort of saying, let's really take a look here. I'm a little nervous about even things like polio. Polio keeps breaking out, and Bill Gates keeps saying we've eradicated it, but it is a tough disease to eradicate, and if the whole world doesn't use polio vaccine, and you do get a big outbreak somewhere and they get on planes, that worries me more than Ebola. I'm worried about, because that's easier to transmit. So there may be reasons even to keep some vaccines in place where you don't really have current anybody getting it, but if the right person travels from the right part of the world, active polio, that could be trouble for young people here. We know what that looked like when the epidemic got going here. It was very dangerous. So complicated equations, no doubt about it, no doubt about it.
One of the biggest roadblocks that they ran into was that the employers' unions, and in particular the American Nursing Association, would not support the mandate. And they were among the few organizations that didn't support it. And I always found that particularly challenging, and wondering what thoughts you might have on that. So
it's interesting. Nurses unions have, in some instances, opposed mandates. And by the way, remember I mentioned that New York State thing about vaccine or mask? And I never told you why it was hard to mask, so I'll tell you now. It's not that masks aren't helpful, but you got to change them often, and you got to wear them properly, sealed. So when they get wet and things, they don't work as well. But mask or mandate was a little bit of a route to say, okay, if you still really don't want to get it, then let's try the mask policy. And it was a little bit of a concession to get the mandate through in New York so that the nurses union wouldn't sue, and they didn't. They said, if you give us an out like that, we'll take it. I'm not sure the masking is all that great. For a lot of people, once they try to wear their mask for a couple of weeks, they get sick of it and just say, finally, give me the shot. This is hard. It's hard to keep changing the stupid thing. But I'm okay with that, try to wear it properly, I'm okay with that. But the main union opposition is this. It doesn't actually have to do with vaccines or fears or being a believer in vaccines. It has to do with something else that's kind of interesting, and that's the right of unions to not have mandates put on them without negotiation. So this issue got into negotiation in some of the hospitals because the nurses said, we're not giving up the right to negotiate mandates with us on anything. Parking, bow to Mecca, cut our nails, whatever you make us do, you have to negotiate that. That's a fair labor practice. And so that's why this issue got on the table. As soon as you uttered the word condition of employment, then a lot of people said, really? And where do we bargain that? So that, you got to bargain it. And I get it. I'm not even arguing about it. I think nursing deans have been pretty good about coming on board in favor of flu mandate, but people don't want to give up that bargaining right. That was long fought for, and I get that. I understand. You're going to go slower then.
When did you first start this endeavor of advocating for mandates, and when did you see your first success? What's the timeline we're talking about here?
So you're talking to a pretty crazy mandate kind of person, although if you want to be gentle, you could say shifting the default, the assumption. Because I started thinking about mandates in healthcare a long time ago, entirely different area. We weren't getting enough organs donated in the earliest days of transplant, and nobody was asking for them. So I said, gee, that's kind of odd. When somebody dies, why don't you ask the family if they want to donate organs? I didn't make them say yes, I just said, ask them. So the first mandate that I came in contact with was decades ago. It was called required request. And all it asked was that you ask a family or whoever partner, whoever's there, when someone dies, would they be an organ donor? And that jumped up rates a lot. Weirdly enough, if you ask, then you get some yeses. It was sort of, no one said philosophers had to be brilliant. They just had to kind of pay attention. So I saw some power in that, and without boring you, I've seen some power in shifting defaults in other directions. The flu mandate thing came up because of these deaths in these children's hospitals. When I saw, we had 13 in a year, it was sort of like, man, that's got to be preventable. That's dangerous. That's bad. So seeing those deaths in that year, and I kept saying to people, well, why aren't the healthcare workers vaccinating? Forget about the world, just there. That was the trigger to me. And we argued it out at our own children's hospital then, sort of listened to the pros and cons, people's worries, people's fears. And there are fears, there's no doubt about it. We hear some, and there are worries about it. But at the end of the day, it seemed to me that was an area where you had to sort of yield to the science or the public health rather than choice or personal concern. It's hard to be a doc or a nurse or a dentist or a healthcare worker and not go with this. So that was the line of thought. And then we, as I said, took it to the nurses. It wasn't a unionized place, by the way. Children's Hospital did not have a heavy nurses union presence, so that was a little easier than some other places you might have gone. People did express fears and concerns about safety and all that, so we went through all that. So ultimately it was the victory in that institution that got other children's hospitals interested, that got other places interested. That's sort of the ripple effect there. And the easiest place to put mandates in remains children's hospitals, because they know. They deal with newborns who can't protect themselves. So they're very nervous about that. And the staffs are committed to doing anything they can to try and help the new babies. They're not going to fight you that hard once you sort of build it in a different direction. They get it. So maybe you got one more here?
As I communicate with people on social media, this is the most difficult one because everybody knows no one would pay any money unless there was clear fault. So do you think philosophically we'll ever revisit the idea of creating such a low bar for causation before we pay out through this fund?
Well, certainly, it's a nice ethics topic for people to get into. He suggested students, pro or con, or whatever you want to think about it. In a lot of ways, getting into these arguments about causation, when you've got a very sick child, it's hard to sort of pull back and say, I'm not going to help. And I understand that, and I want to help too. On the other hand, people say you're still building up. Let me change the context. You'll see. I'll give you a different example. This is a fun one to end on today. Years ago, I had a guy who was in a terrible car accident, and I got called in as the ethics guy. He was bleeding out, losing a lot of blood. For those of you who know anything about medicine, he had a hematocrit of 8, which meant he had fumes of blood. There was no blood in him. But he was talking and communicating, although how, I don't know. But he was very articulate, and he said, I don't want blood, I'm a Jehovah's Witness. So they called me in and said, would you talk him into taking blood? So I said, you're going to orphan your kids. He had a couple of kids, but his wife said he didn't want blood, and his religious leader had come in and said he didn't want blood. Jehovah's Witnesses like medicine, they just don't want to take blood. And he said again and again, I don't want to, and he seemed competent. No psychiatrist was going to deem him incompetent. That was it, no blood. I'm actually getting to your question, you'll see how. So we leave. And I don't know what made me do this, but I said, I got to go back and ask him one more time to myself in my head. So I stick my head in the room, there's nobody there. I said, well, you sure you don't want blood? He said, I absolutely want blood. He was not going to say that in front of his wife. He was not going to say it in front of his religious leader, but he did want the blood. By the way, future lesson for you budding bioethicists, always get him alone. So he says yes. And we did transfuse him, but he said, I want you to lie for me. I don't want anybody to know I took it. So he's in the Jehovah's Witness list of people who didn't need blood and lived, even though we said he did. Am I going to reverse that? No. I mean, I respect his right. I get that. I'm tougher when you're infecting other people. I'm not still sure how far I would go to build the exemptions. I can go with the mask as an option if people really still don't want to vaccinate, as long as you wear it right. For the compensation fund, I hate leaving people with an injured kid with no money. I don't really care how they got injured. I know it builds causality claims, but it's still, kid has neurological impairment, whatever. Are you 100% sure? Is there a 1 in a gazillion chance that the vaccine did? I don't know, and I part of me just says help them. And if the only way to help them now is through the compensation fund, help them. If we had universal health care that was decent, you probably wouldn't need the compensation fund as much. They don't have it in some other countries because they don't have to get into litigation to get your health care costs covered. So that's a long-winded way, but I've never outed the Jehovah's Witness. He's in the evidence base of Jehovah's Witnesses for people who live without blood. He did get blood. I like to think of myself still as patient-oriented at the end of the day. So that's a long answer, but I'm not inclined to go to war with the compensation fund. But if some students want to get into that issue, that's a great topic. It's just an interesting one about what we owe people who think they may have been injured and how to handle people who may think they've been injured. If there's an upper limit, I don't know what it is, but I do understand the concern about getting overloaded with vaccines. And I understand it partly as a vaccine content, but I also understand it if you take your kid in and you look at the vaccine schedule and say, you got to stab this kid 12 times today, that's a lot. So there may be arguments about stretching the schedule. I'm familiar with those. Part of me wants to say I'm more comfortable with that than no vaccine. I'm much more comfortable with spreading them out. And as I said, there's some vaccines like anthrax, some rarer ones, I don't know, that you have to get them. You're not likely to get the disease. I'm not sure they're going to be useful that way. But I wouldn't mandate a big package, if that's what your question is. Well, here's the honest answer to the cumulative, and I'll end on this note. There is a lot of vaccines, and they're certainly on the scale. I don't know what the arguments are against in terms of worrying about a certain amount being there. But when I see somebody have their baby licked by the dog and then crawl on the filthy carpet, I always think to myself, now that's an overload. There's a lot of bacteria and viruses in those dogs that I had my dog lick my kids, and I kept thinking, what am I, an idiot? This thing's an infection pool.
Please help me thank Dr. Caplan.